Good morning again, and let's get started. Hello everyone, I'm Nick Pearce. I'm the Chief Operating Officer at Centenary Institute, and I'm stepping in for Sam Ludoff, who was going to facilitate this session. Unfortunately, she couldn't make it, so I've stepped in at the last moment, and hopefully I'll live up to the high expectations you would expect from her. My background is I have a PhD in immunology from a couple of years ago, and then I also have an MBA. And what I love about my role in Centenary is I get to work with the researchers and turning their ideas into experiments and then hopefully seeing how they then get integrated into improving the health of all Australians. And for that, that includes everyone who's on this seminar, the general public and our consumers. I'd like to start by acknowledging the traditional owners of the land of which the three of us are sitting on today, which is the Gadigal people of the Eora Nation, and pay my respects to their elders, both past and present. Some things just we're going to go through. This webinar is being recorded. There is a Q&A button down the bottom, so you can put your questions into that, and we will answer those questions at the end of the two presentations by our two speakers. If we run out of time and don't get to your question, don't worry, we will answer those questions in an email response to you. As I said, this is being recorded, so you can actually access it after the event. It will be emailed to you. Finally, we will try and answer all your questions, but please keep them at a relatively high level. We are unable to answer specific clinical questions because we can't provide medical advice over this webinar. I'd now like to introduce our two speakers. So firstly, centre head and sitting directly next to me, Dan Hesselson. Dan is an internationally trained research leader in regenerative medicines, looking at how the molecular mechanisms lead to regeneration. He's done some training in some wonderful places like the University of California, San Francisco. Sitting next to Dan Hesselson is Yagiz Aksoy. He's a clinical researcher and an AI innovator. He has an MD from the University of Sydney and a PhD from Macquarie University. His role includes looking at the ethics, governance, and clinical trial involvement of AI, and has been involved in projects that have set new benchmarks in predictive medicine and clinical decision-making, including AI-powered tools for cancer diagnosis, treatment response, and post-operative complications. And with that, I'll now pass over to Dan and ask him to give an overview of his centre.
Well, thanks, Nick. I'll start with just a brief overview of what we do here at the Centenary Institute. The Centenary is a world-leading medical research institute, and our strengths are in making basic discoveries and translating them into innovations that can improve the diagnosis, treatment, and potentially even cure some of our most serious diseases. We focus on diseases that create a big burden for our society, and we organize our research into centers. The center that I lead is the Biomedical AI Center, which kind of cuts across all of the disease areas, and you'll hear more about that today. But the main diseases we work on are cancer, cardiovascular disease, inflammation, and then diseases of aging, rare infectious disease. Our scientists are some of the best in their fields, and they're dedicated to solving these major health problems. We're located within the precinct of the University of Sydney and also the Royal Prince Alfred Hospital, and we're close to the University of Technology. And this gives all of our scientists, many of whom are also professors at these other institutions, the opportunity to translate some of our major findings into practice. And so the Biomedical AI Center is interested in various aspects of applying AI to health, but in particular, we're interested in how AI can be used to make proteins do new things and things that are relevant to disease. And so in this slide, you can see on the left is an image of a protein that was designed by an AI to bind to a target. And what we do in our center is we take these computer generated proteins and then introduce them to the lab and improve them so that we end up with designer proteins that couldn't have been made by any other method. Next slide. And so I'll give you one example of how we are applying this to regenerative medicine, and this relates to heart disease. And so after a heart attack, our hearts form a scar tissue which compromises their function, which compromises the function of the heart after recovery. However, we've taken inspiration from an animal called the zebrafish, which after a heart, equivalent of a heart attack, can fully regenerate its heart and form a properly functioning heart muscle. Next slide. And a few years ago, with our collaborators, we discovered that there's a gene that's produced by the zebrafish heart called KLF1. And if this is turned on in the heart, this makes heart muscle cells grow much, expand and grow a larger heart, and is essential for that regeneration process. And in this picture, what you can see on the left is a normal heart, and then a much larger heart after we've turned on this particular gene. And on the right is a view through the heart showing that the heart muscle looks healthy, but it's just bigger. Next slide, please. And so how we are addressing this using AI is that we start with the human version of this protein, which has very little regenerative capacity, and we are designing new proteins that are predicted to have a lot more activity. And then by taking those into the lab and further optimizing them, we hope to end up with new therapies that could be used after a heart attack. And last slide, please. And the eventual goal here is to deliver these proteins to the part of the heart that's damaged, near the damage after a heart attack. So in the bottom right of that diagram, you can see the black dead heart cells. And if we could deliver these new therapies to the region right next door to that, potentially the muscle could regenerate. So that's one of the regenerative projects that we're the flagship of our AI center. And so, yes, I think that kind of gives you an overview of the types of approaches that we use and how we're hoping to take AI from the discovery stage all the way through to translation.
Thanks, Dan. Pass over to Yagiz to give his presentation.
Thank you, Nick. Appreciate that. Hello, everyone. Thank thank you for joining me today and us, whether you are sitting here in the room or tuning in online from your laptops or mobile phones. I'm very pleased to be here, and we'll be talking about how AI is reshaping the healthcare. So I'm wearing multiple hats, and then probably each of my slides will be linked to the hat that I'm wearing. Essentially, I'm a clinician working full-time doctor at Royal North Shore Hospital, currently second at the Port Macquarie Base Hospital. Previously, I have a background in research, and it's a very special day today because Dan was actually my thesis supervisor. I think it's been a decade since we know each other. Of course, that work was about genome editing tools, but I'm very pleased to see that we are independently and converge and meet again to talk about AI. So what I want to mention is perhaps I want to start like this. So AI in healthcare, I don't want to use the term artificial intelligence, but perhaps augmented intelligence, because I see AI as a supportive decision tool to augment the human intelligence that we use in the hospitals. So I believe even with all the booming tools out there, doctors and nurses and allied health professionals will be in charge. Hence, I kind of like see of it as, if you think of AI as the GPS, your healthcare professional is still sitting at the driver's seat and driving the car. Now, the AI can give you some suggestions like, did you like to take this route, or did you like to take that route? And the driver can take that into account, but ultimately he or she is the one responsible of driving the patient to the destination. And some of the routes that we take every day, perhaps you don't really open your GPS if you're driving from work to home because you know that route so well, you probably wouldn't even want to spend 5 seconds to turn it on. And it's similar in clinics. Some of the things that we do, it's stuff that we do every day, some procedures. We don't need to rely on AI, but every now and then there are those complex things, and in those instances, it would be I can see AI being a major tool that's supporting the clinician to decide on a particular pathway. So what does the current AI landscape look like, and how do these tools fit into our current landscape? We can go to the next slide. I kind of like think of the healthcare as a major jigsaw puzzle. And most of the AI tools that we have today focus on specific tasks, like generating chest X-ray reports or analyzing heart rhythms. But they are just individual pieces in the entire puzzle. So, for example, if you know if there's an AI tool that can give you the report of a chest X-ray, that's good, but that opens up a quite number of branches. Think of them like alternative pathways. Maybe you want to consult with another physician to ask about that. Maybe you want to have a discussion with the patient about potential pathways. Maybe you want to biopsy based on that. Maybe the consult asks you, oh, this is interesting, we need a CT scan. So eventually, these individual AI tools can be linked to create a chain that drives the kind of all this complicated pathway. But at the moment, they're individual pieces of a big giant puzzle. I think it's worthwhile to mention that many of the current AI tools are at the moment focusing on imaging-based tools such as radiology, and that's why I put the chart there from FDA's approved AI tools, which are currently in practice. And eventually, this probably will slightly change, and it will involve other specialties to start using AI more frequently. But with all these tools, if you were to ask me what's one of the biggest challenges AI is addressing today, we can go to the next slide with that. I would say that it's the allowing doctors to have more face time with the patient. It's actually surprising that one of the biggest, I would say, issues that I see in healthcare now is perhaps up to 40 to 50% of doctors and nurses' time goes into typing. So we are taking best and brightest and doctors and nurses with the most compassionate care needs, and then that they spend quite a bit of time just typing notes on the computer. And I often see it in the clinics myself as well. You would, and you can see, like in the first picture, you can see the doctor furiously typing on their computer. It doesn't really serve, it just takes away from the valuable face time a doctor would have with their patient. With the current tools that we have, I can see that AI can definitely handle the documentation, which is quite important, but all at the back end, while allowing doctors to spend more time with their patient. And I think this is one of the solutions AI can bring to practice, which would ultimately benefit the patients, but also would probably please lots of health professionals. Just to give an example, I think this was last week, as I was completing my shift in the day, and as being a junior doctor in a hospital, so I do quite a bit of typing and notes and discharge summaries. But there was one, and I remember this patient who was supposed to be discharged from the hospital on that day, but received at least 3 to 4 different opinions throughout the day. And it was a bit ambiguous whether she's going home or not. And she's just waiting in her room, not really knowing what's happening. And towards the end of the, after finishing my task, I decided I'm going to spend some time with this patient because I think she really wants to understand. And I spent a good 20, 30 minutes explaining her, look, this is how your day started. We saw you here in today. Then we found out your blood results that triggered infectious diseases to come and see you. And this is what they told you based on this. And they recommended a further imaging, which we did today. And that's what it showed. And just showed her the full summary of the day, what exactly happened, what made each of the clinicians decide to take a certain pathway, and this is the full summary of it. And I can say at the end of the day, she was extremely pleased with this information, and because it's actually making sense now, and it also gives me a lot of job satisfaction as a doctor as well, because I can see that satisfaction and this almost sacred patient to doctor connection. And I think if it were to, if AI could support the doctors by handling this sort of typing and documenting in the background, it would allow most of the clinicians to have this valuable face time with the patients. And I think this would be one of the quick gains that we can get from AIs today. But I also want to say, with so many AI tools that are in the market right now, and I talked about how they're each targeting a specific task because these are single model technologies, we are, and some of the companies are actually going into the multimodal assessment as well. And maybe if AGI becomes a thing in the future, it might actually start addressing the patient need as a whole. But at the moment, I think these specific task-focused decision support tools are very valuable. I just want to give an example of some of the tools that I have engineered over the past 5 years. We can go to the next slide. So this tool is an effort that I have developed with colorectal surgeons and pathologists in the last 3 to 4 years. So in a nutshell, so what it does is, if you have a polyp that is known to be malignant, that essentially means that, so you can think of polyp like a small growth in your colon that has cancer cells. Now, if you have it, the options could be either to remove the polyp or resect the bowel. So removing polyp is a very minor procedure. It's a 40 minutes, very safe procedure. But the question is would you be still at a risk of developing cancer in your colon later on? As opposed to you can have the bowel resected, but it's a very major operation with potential complications and slightly reduced quality of life or discomfort. But it would be a more definitive solution to address the increased risk of cancer. This would be a decision usually led by the surgeon looking at the colon and with their experience. An experienced surgeon who's done thousands of colonoscopies and polypectomies might actually say, okay, I think to the patient, look, I think it might be a best idea if we can resect the colon. And there are some guidelines available, but this idea came one of the co-lead authors of this paper that we published, Dr. Andrew Zanuck. If we can, for example, design a tool that shows the actual risk factor to the surgeons and the patients, it could be a great decision support tool, which then surgeon can use to talk with the patient. And this is supposed to be a video, but you can go to the website here to just see how the tool plays. You can enter your individual data to the tool, and it would kind of like give you your individual risk score, and that would guide the surgeon which way we should go. And in the next slide, I just put it there, so not to talk about them in great detail, but similar practical AI-enhanced tools which can guide essentially clinicians in their decision making. And I have included the QR codes if anyone wants to just scan and go to the tools. But essentially, these tools are just decision support tools. They are AI powered and just adding an extra perspective so that to the clinician before they can make a decision in partnership with the patient. Next slide, please. And now wearing my ethics hat. Previous to my role as a doctor, I used to work in New South Wales Health, looking after research ethics. And I cannot not talk about the ethics issues that are associated with the AI tools. The first of all, I think I would mention about the, and this alone could be an entire talk, so I'll only mention just a few points. But one of them is the issues the AI tools are facing today is that this the tool itself is a continuously evolving tool, and that's where its power lies. But because of the locked learning policy of FDA and TGA, essentially what it means is to make sure a software always delivers the same reproducible result, you are locking out the tool with whatever the data it's used to train the software. However, AI is a continuously evolving tool. When you do that, you are potentially limiting its full power. For example, in the tool that I was talking about, which helps the surgeons to decide which way to go if you have a malignant polyp, we can continuously enhance that tool by feeding more data to it. However, if we were to fully deploy it as a software in a clinical setting, we have to lock it up. And if we want to further like enhance it with more data, that requires another application to TGA. Now, FDA is kind of like addressing this problem with different models such as PCCP, predetermined concept change plans. I think TGA will get to follow suit. But the main trouble is, and the reason for giving this example is, the field is evolving so fast that our policymakers are not really trying, like that they're trying to catch up, but it's really a challenging task. It's a good problem to have, yet it is a problem. And on the ethical side, I guess there are a few things to talk about here, but one thing that I want to highlight is the black box of AI, especially all these the new tools that are used, supervised learning, especially things like deep learning or neural net, these are fantastic tools. You can give an input, you can train them to predict an output in simple terms. For example, you can just feed them with a lot of like skin images, and you can train them to predict whether the patient, actually to see if the patient has a skin cancer or something else. And they're doing fantastic work, but we don't know actually how it does that. That's the black box of the AI. And the challenge with that is, if we were to start making more sophisticated associations, such as there are some companies now who can actually look into someone's retina, it's a tissue at the back of your eyes, and predict if you're going to have a Parkinson's disease or not. Now, this is fantastic, except that we don't exactly know how AI can do that. So that black box there poses a lot of ethical challenges, because if you were to deploy that tool, you would be enjoying the outcome, but without understanding how that actually works. And that also brings the other issues like bias and health equity. And also the privacy is also is going to be a big ethical challenge, as a lot of patient information is going into these tools, and it's producing valuable outputs. But it's very important to know how that data is managed. And with so much, and if you think of that, data is the fuel for AI, and AI will always need more data. We are at a point to see how can we actually ethically manage all this data coming from patients, and how can we make sure that they're only used for what they're intended to be. Next slide, please. I guess I want to conclude with the future of AI in clinical care. I think it is not a matter of if AI, it's more about when and how question. And we can talk about the so many different examples of how AI can be used in clinical care, and I'm happy to answer some questions. If I were to single out one particular topic, I would say it would be the drug discovery, which is what Dan was talking about before. I do believe that's the next frontier. All the tools that I showed before are great for diagnostic, decision-making, and support tools. But I think one of the biggest winning points of AI would be in the future its ability to help us streamline the drug discovery process, to generate after the drugs that are predicted to work quite well in the clinic, and do that at a fraction of the cost. It has its lots of challenges, and as I said, the data is the fuel for the AI, and we don't have the AGI or like the full agency power of the AI is available yet, but it's predicted to come. But I just want to point that the basic research, like the one that Dan is doing, is quite important, because it is that research that will be generating that valuable data, which then can be used to make more effective drugs or create altogether new drugs. And I think that will be one of the determinants of how well we can fully deploy AI in the translational healthcare. And I guess I'll stop there. And yeah, thank you.
Thank you both for those wonderful presentations. We'll come to questions in a second. I might just take the prerogative of starting with a question for you, Dan. And Yagiz was talking about at the very end there that AI produces a lot of data and can be really helpful in the way we're going to produce new drugs. But do we run the risk that AI will just generate so much data it will impede rather than accelerate our drug discovery?
Yeah, I think that's an interesting question. I think it's going to be very important to validate what the computer produces. And so I think I touched on that on one of my slides, but oftentimes the computer or the AIs will produce drugs or proteins that are predicted to do something, but until we actually test them, it can sometimes go off on a slightly wrong track. So I think the power will come from predicting things, testing them in a lab, and then feeding that back into the models so that the AIs get better at producing things that are actually valuable in the real world.
Great, thank you. And we've started to get questions online, so I'll go to one of the online questions. And thank you, Martin. Isn't it inevitable that computer diagnosis of medical conditions will become the norm using AI?
It's a tricky question to answer. So again, in terms of diagnostics, I can definitely say, so genie is out of the bottle. It's not going back. However, I guess if we're only talking about diagnostics, it might be the way in the future where the AI-enhanced tools are heavily used to guide the clinicians. But at the moment, the fully autonomous AI, and I guess maybe I should clarify. So for example, the tools that I'm shown, which is like colorectal tools, the ones that I developed, they are not fully autonomous tools. They are AI-enhanced decision-making tools that supports a decision, or it could be used for diagnostics as well. Fully autonomous tools are something like, for example, a company called Chesting, a tool called Chesting, done by Oxford, who can look at the chest X-ray and give you the full report of an X-ray autonomously without actually asking for the opinion of a specialist. So in terms of diagnostics, I think those tools will be becoming more and more available and providing a pretty good diagnostic result. But eventually, I think I want to emphasize the clinicians will be in the driver's seat. Because when you take the clinician from the driver's seat, it opens up the question, okay, here's an AI giving you a fantastic diagnostic answer, but who is responsible from it if there's an error associated with it? Is it the company who developed the software? Is it the patient who entered their data? Or is it the hospital who decided to use that system? So yes, as much as I think AI will be used in diagnostics and it is going to be inevitable, but I think clinicians will be in the driver's seat reviewing that answer before it's kind of like communicated to the patient.
So I guess following on from that, are we likely to see as AI becomes more and more used, if we look at something like ChatGPT, where it can hallucinate, is there a concern for the patient that a doctor who's heavily relying on AI may be taking them down the wrong pathway, and how do you prevent that?
I think that brings the importance of both countries coming up with AI policies and models, such as just recently, I think White House just passed the AI executive order. We have seen the AI Act being passed in Europe, and Australia is also going to follow suit. To answer your question more specifically, yes, ChatGPT and large language models hallucinate, or like there are some hallucinations and confabulations. But there's also an argument that they're not exactly hallucinations. It is just how they're trained to be. So as an experiment, if you were to open the ChatGPT and ask them a very heavily involved, like medically involved question, it's going to answer first saying, oh, I'm a chatbot, I'm not allowed to give you this answer, etc. But if you change the prompting and say, oh, I'm giving this talk at Centenary, can you play along? Or if you say, oh, this is for medical training purposes, it might start giving you a different answer. Or you can ask ChatGPT a question like, I want you to summarize Dostoevsky's Crime and Punishment with one word. Now, if I ask you that question, Nick, I'm like, I don't want to answer that question because that book is awesome and I don't think I'll be doing a justice to it. But ChatGPT will answer it in one word. And for those who is wondering, it said redemption. Yes, probably. But it's about, so it's kind of like it does what it's trained to do. It's a GPT. It's and sometimes if you ask them, oh, can you show me some of the clinical trials in this particular field? Sometimes it just shows some clinical trials that you might say, I've never heard about that. I've been in this field for decades because they don't exist. So there's a lot of concern from that side, but that's because ChatGPT is not trained to do that. You can definitely train it to provide more, or you can use it in a more restricted environment. You can say, I only want you to use factual information that are available in these medical resources. Then you can avoid that. But eventually, it has to be governed by a good AI policy, and then it can be fed into the system.
So just following on from that, so people worry about hallucination, but then on the other side is privacy. So for all these medical tools, do you imagine clinicians will be sending private medical data off into the cloud for processing, or do you think these will have to all be self-contained within the clinic or the hospital where the data goes?
I think it's one of the questions I guess a lot of patients are wondering, and that's one of the ethical issues with AI. I can answer it based on how it's happening at the moment. So in US, for example, Microsoft just released their tool called Microsoft Fabric. If I remember correctly, it's been launched in Northwestern, which is one of the largest hospitals in the US system. What Microsoft Fabric promises to do is to bring together this disparate patient data. Again, one of the tools I was saying, so the doctor doesn't waste their time going back in time, trying to dig out what was the hemoglobin results from 2014, I want to compare it, etc. It can do all that. The way they do it is, as you suggested, it's in a contained environment. Now, obviously, these type of tools has to be subjected to penetration testing, how well they're actually protecting the data, if there were any kind of like risk of that data leaving the environment, or I am providing this very valuable patient and private patient information. Can we be sure that this is only being used for its intended purpose? And that requires a good AI research governance as well, because as a researcher, you might be tempted, wow, look at that decades of like data. Imagine the questions we can ask to this data set. Well, if it's not defined in the original, the context and scope of what that tool is allowed to do, then no, you shouldn't be doing that. Yeah.
That might lead into a question we have from Glenda, where she goes, how are you checking on the drugs? So in reality, how do you ensure that AI is giving you the drugs that you're really after?
Yeah, so the work that we do in our center is heavily lab focused. And so the very first step after we get a prediction is we might take 10 or 100 versions of that new protein or drug and test it in the lab. And so we don't do anything without a very quick first test to see is it on the right track. And then from that point on, as I mentioned, hopefully we can feed that information back to make the next prediction better. But all of the usual testing and looking for potency and specificity happens the same way it would for a traditionally discovered drug.
We've got another question. How could AI be integrated into the surgical aspects of medicine? And then is Centenary doing any work? So maybe, Aziz, if you do the first part, and then Dan, if you want to jump in for the second part.
Sure, surgical aspect.
Yeah.
Right. I guess it's a bit of a broad question. So if you're talking about autonomous surgeries, that's already happening. So you might have heard about the robot called, come from Leonardo da Vinci, so the Da Vinci systems. There is actually a currently functioning like robots that can be used in surgery pretty efficiently. And like, I'm not a surgeon myself. I've only kind of like seen this in hospitals, but some of the surgeons are currently being trained, as you might see next to their titles, robotic surgeons, that often relate that they're trained in using a or like that they're trained to perform their surgeries using a robot. Now, I'm not sure we will be at a level where fully autonomous robotic surgery would be possible, and which I don't see why not, because as in everything with the surgery, you have a certain steps that you follow, almost like a very well-established recipe, and AI can either like power these tools or it can be directly involved. But on other aspects of surgery, some of like the example that I gave, for example, the AI-assisted tools, such as the colorectal malignant polyp tool that I mentioned, that would be just an extra tool for surgeon to make a decision. So that already is happening, and it doesn't, again, think of AI like a GPS. It doesn't drive the car. It just shows the route based on real-time data and evidence. And that just helps the surgeon to make a more informed decision and provide a bit more information to the patient in a partnership decision.
And just following, in respect to what's happening at Centenary, so just in talking to my clinical colleagues here, those types of tools, like Yagiz has mentioned, have definitely become part of their practice in terms of consulting them as part of their decision making. So there's stories from all different areas that are coming through.
And to follow on from it, there's a question that asks, will AI medical technologies become available to non-professional clinicians? So it's really about broadening out some of these technologies that you're relating to. And, you know, I can think of Dr. Google type things, you know, how far we can go and at what point do these things become available to the consumer and the general public?
I think that's one of the dangers of AI. I should actually have that in my slide. So I think there was a picture saying Dr. AI. So everyone knows the most popular doctor in the world is Dr. Google. I think it's about to lose its place. It's going to be Dr. AI now. The problem is these type of large language models they're so easy to use. They're so easy to use. So that makes it available to anyone. Now, it is not a bad thing. Because if you think about it, self-serve is becoming one of the things that we do almost every day. We have self-serve checkouts. I don't remember the last time I used a travel agency to make my booking. Especially the young adults are more like using these type of tools to ask questions about their health. Now, the danger lies in when you rely entirely on a model which is not trained to provide that information, the final decision point might be the tricky one. Now, I'm more than happy if my patients are coming to me with those questions. I don't judge patients and saying, oh, I asked ChatGPT, that's what it said. I'm like, great, did you ask this question as well? I'm all for it because I'm happy to explain all this. Or if I don't know, I can just ask the senior consultant, or like, oh, that's a great question. We can ask more questions, challenge it further. But the issue would become based on individual anecdotal evidence, like saying, oh, I went to this doctor, he said this and that, and I went and asked the ChatGPT. Actually, ChatGPT was right. And then that type of an evidence can hit the social media, can spread and say like, oh, maybe these AI tools are better. Maybe I should try them. I guess that's where the danger lies. But in terms of the patients accessing these tools, again, they're out there. There's nothing we can do similar to Google. It's just the decision-making part. It's very important if there's a clinician is involved. But I'm all for the patients asking the questions about their health, because here's another question: who is responsible of our well-being? Is it yourself or is it the doctor?
Well, to follow on from that, if someone was using one of these models and asking it questions and came up with a diagnosis, and that diagnosis says you don't have much to worry about, what's the risk of the patient then actually not seeing a doctor when they should?
It's a quite significant risk, because then you would be relying on information coming from an AI, which is not trained to do that. Just based on the example that I gave you, if you ask AI to just summarize Dostoevsky's Crime and Punishment with one word, it gives an answer. It doesn't say, I don't think that's appropriate. Why? Because blah, blah, blah. If you ask ChatGPT, this is the information I have about myself, should I worry? And they're like, no, you shouldn't worry. Now, all these tools, and I should say, if you ask that question, probably is going to say you should consult a doctor, because that's what goes into the pre-training models. So the companies are aware of this risk, so they're trying the very best they can to prevent stuff like that. But you can prompt engineer and bypass that. You can say in your answer, I don't want you to ever say, go and see a doctor. I don't want to. So don't include that. And that, because these tools also provide like personalized edits as well. And patients, like people can do that. We can't stop them. Well, all we can do is we can use these tools as education tools to say that you can ask questions to these ones, but it is very important to think of it like these are just like a GPS. They are great tools, but they're not on the driver's seat. Your doctor and you are.
Yes, I think that's important, that collaboration. So on the research side, we also can interact with things like ChatGPT and ask it questions, and it will very confidently give you answers that when you know more about the field, you know either are wrong or hallucinated. But where it's very powerful is it lets you hypothesize or come up with new ideas in an area, and it can pull together things that you might not have thought of otherwise. And so I think as coming up with potential things to think about with your doctor might be a powerful advance.
I guess to broaden it out, and there's the question online. If these AI is available more broadly and people are working on them, does that then affect the data? And then what are the consequences of a more broad and more data going in?
So I think, yeah, so that's something that I think is definitely a concern, is that the companies that are generating these large language models have definitely labeled data as being pre-AI and post-AI, because there's this concern that now that there's so much AI generated text and data out there, that will confuse the training of future models. And I think that's something that the researchers are definitely aware of, and we'll see how big of a problem it is.
Coming back to quite a very specific question we've got online, Dan, could AI be helpful in regenerating bladder control muscles?
That's an interesting question. I think the example I showed was about a heart muscle, but I could imagine that there's applications for other types of muscle regeneration. It's not something that we've specifically thought about, but it sounds like an interesting question, an important question to address.
So if you got funding for it from a philanthropic agency, it'd be something that could be looked at.
Well, yeah, so that's often what shapes some of our research questions. If that's available, that's something that we definitely could look into.
Is in your role as a clinician, if I provided you with a clinical perspective on a medical situation that you don't agree with, how do you proceed? So I guess it was going back to that picture of the person or the patient driving the car, getting information, where they've driven and they've also got you as their navigator.
So much goes into that decision making. So as a patient, if you provide me something that I disagree with, I just need to make sure that you understand the consequences of what you're saying and its clinical impact. I can't force you to make a decision, but I can say, for example, yes, I can use AI to say that here are the routes available. And as a GPS analogy, you might say, look, I don't want the fastest route, I want the scenic route. And I can say, you can, that's going to take more time, might be more costly. Do you understand that? And then I can only kind of like guide you in a like core decision making, rather than kind of like saying, no, you're wrong. But if you are making, just based on what AI told you, a claim about your own health, my job would be to actually try to show you the full picture. In fact, probably I can help you to say why probably that AI is saying what you said. Maybe your initial data entry was missing a couple of points. So it's a core decision making in the end.
Great, thank you. I'm just conscious of time, so I think I'd like to thank both Yagiz particularly for coming all the way and taking time out of his busy clinical schedule to talk to us all today. I'd also like to thank Dan, one of our centre leads, for sharing his insights and his research. I'd also like to thank everyone who's online today, particularly those who ask questions, and just remind everyone that you're all our consumers and we are really fond of these presentations. We love sharing our science and our thoughts with people. People might think researchers are really shy, and quite often they are, but once you start talking to them about their research, you really see the passion they have for the work they do. So Centenary has a consumer panel that it's always trying to recruit to. There's more information on our website as to how you can be involved. And that can be as simple as, you know, coming and doing a tour of our facility. We love to show people what we do. A number of the granting bodies now require consumer input into grants. So we love that we can call on people to review our grants as part of the consumer review process of that grant application. And, you know, it also allows consumers to refine what our researchers are actually doing. So the more we hear from consumers, the more that feeds into our research, because it is an evolving process. So on that final note, I just again like to thank our two speakers and thank everyone for being involved today, and hope you enjoy the rest of your afternoon. Thank you.